Now it's my pleasure to introduce Professor Joe Beeman. He has taught here for approximately 22 years. In fact, I think you're in your 22nd year
Yes.
right now here at JCC. He earned his bachelor's degree in biology from UC Irvine and a master's degree from Cal State LA in biology with his emphasis in neurophysiology. So he loves the brain and the spinal cord. Yes, he does. Yes, he does. His area of interest is neurophysiology and neuropharmacology. So once again, Psych has a real affinity for Joe Beeman and neuropharmacology.
It goes both ways.
Yes, yes. So, works with all kinds of human physiology. He's in charge of the Herpetarium?
Herpetarium, yeah. Yeah, just a bunch of snakes, yeah.
Yeah, a bunch of snakes. I don't even like snakes. I don't like to stay that way. But anyway, he loves them, so he's in charge of them. Joe's married with 3 children, loves to swim, enjoys the outdoors. And the other thing I want to say about Joe is that he has been so influential in so many of our students' lives over these 22 years. So his students have gone on not only to become physicians, to become nurses, nurse practitioners, PAs, physician's assistants, go into psychology, dentistry, pharmacology, but he has really sent our students out into the world, and they have been really excellent in all of these professions. And he has some psychologists that follow him and really love him and have gone out into the field too and have gone into neuropsychology because of Joe. So without any further ado, I'll give you Mr. Professor Joe Beeman.
Okay, thank you. All right, thanks for that introduction. There's a lot to talk about, and I have such a short period of time. So I'm going to get right into it, okay? Does that sound good? All right, let's do it. So I'm going to talk about tobacco first because it has the most research that, that backs up everything that I'm talking about, all right? So let's go into tobacco. With tobacco, what we have to look at is all of the different chemicals and compounds that are found in tobacco. There's about 7,000 different chemicals and compounds, not all of them bad, but of those 7,000, about 69 of them are known cancer-causing agents, and hundreds of them are toxic. So I've just given you a kind of a short list of some of the more toxic or cancer-causing ones here, so you can get sort of a little flavor for it, a little idea as to what's inside of tobacco, products, all right? Now, the way I'm going to approach this is to first look at the way that, the Center for Disease Control kind of looks at this. And every year, the CDC says that about 443,000 people in the United States die of cigarette smoking complications, something that's related to cigarette smoking. That's a lot of deaths. And if you look at the different causes of death, they fall into general categories. Cancer for sure, and everybody knows that we cause lung cancer and other cancers of the body. We'll talk about that. Heart disease, that's something that people don't think about, but I'm going to talk about it today. And then chronic obstructive pulmonary disease, we'll talk about that also. I'll get a little definition and show you that. And some other diagnoses too, including stroke. So when we look at the information coming out of the CDC, and then we look at the 4 leading causes of death, all right? Number 1 is heart disease. That's the number 1 cause of death. Number 2, cancer. Number 3, strokes. And number 4, chronic obstructive pulmonary disease. So the top 4 leading killers of people in the United States, and here's the scary thing about it. Tobacco use is the number 1 preventable risk factor for all 4 leading causes of death. So this is something that's serious, something that we need to take a closer look at. And the approach I'm going to take is to look at the 4 leading causes of death and how tobacco can contribute greatly towards those, all right? So, first, let's look at heart disease, number 1, and stroke, number 3, okay? And let's see how the tobacco, the ingredients in tobacco can contribute towards heart disease. This is a picture of a plaque formation that occurs inside the arteries. Atherosclerosis, we call it in science. And that's where fats, cholesterol, white blood cells, even smooth muscles, build up inside cells, build up inside the wall of the artery. You've heard about it before. And it causes the arteries to narrow so that the opening that has all the blood traveling through it gets smaller and smaller. Also, these plaques can rupture and then have pieces of them travel to smaller arteries, cause things like stroke, heart attack, all kinds of different complications. And this is the number one reason for people getting, heart disease and stroke, is this plaque buildup in their body. So my approach is to say, all right, let's look at tobacco, and can tobacco contribute towards this plaque formation, which eventually leads to heart attack and stroke? And the key is this. In order for a plaque to form inside the wall of that artery, there has to be some type of compromising that occurs to the inside wall of that artery. So when I look at that inside wall right in there, that has to become compromised. It's called the endothelium of a blood vessel. And if that gets compromised, then all the rest of the plaque formation, everything can occur. If it's not compromised, you're not going to be able to get in there and cause damage to that wall of the artery. Does this make sense? All right, so with that in mind, let's look at how tobacco can cause problems with that endothelium. So first of all, the toxic products that are found in tobacco, and there are a lot of them, added to the bloodstream from cigarette smoke definitely causes atherosclerosis. So let's just kind of list the different things that we see in the literature. The arteries in women who smoke show significantly more problems, holes in the endothelium, this lining that lines the blood vessel, allowing for more damage to occur to the endothelium and eventually plaque formation. Not only that, if they happen to be taking pharmacological substances like, let's say, birth control, oral contraceptives, that complicates the problem even more. It adds to that damage to the endothelial lining because they're synergistic with each other, the tobacco products and the drugs that they happen to have in their body. So this is not a good thing. When you look at umbilical arteries from infants born to mothers who smoke, they show endothelial changes like widening of spaces between the cells, swelling of the cells, problems with this endothelium. Again, it's like the theme of how you're damaging these blood vessel walls. You're damaging this endothelium and allowing this plaque formation to occur much more rapidly. If you look at smoking 2 tobacco cigarettes, it more than doubles the number of damaged endothelial cells that end up in circulating blood. So the way that a lot of times they can tell if a blood vessel has been damaged is they measure the amount of endothelial cells that have broken off of where they normally should belong, and they're just kind of traveling in the blood. And when you measure that, you can see, hey, there's a lot more if you smoke these cigarettes. And then if you look at humans and look at their platelet activity. Platelets, they're called thrombocytes, kind of a fancy name for them, but platelets help the blood to clot properly. And there's definitely activation of platelets, adhesion of platelets, especially to these plaques that are forming. To anywhere where there's damaged endothelium on the inside walls of the arteries, the platelets tend to stick to there. And that can become a problem because you can form a blood clot right on top of a plaque that's forming, and that blood clot could break loose. There's all kinds of problems that could occur. Occlude the blood vessel eventually, something like that. So this is well proven, lots of different studies, and also proven in secondhand smoke exposure. So if you're around somebody who smokes all the time and you're getting that into your body, then you're going to have the same problem with altered platelet activity. And that's something that could lead again towards this atherosclerosis. Young and middle-aged smokers who don't show any sign of any disease yet, and they're like, hey, it's not going to affect me, I'm smoking, it's not going to affect me. If you look at their arteries, they're showing signs of arterial sclerosis already. In other words, arterial sclerosis, for those of you who are not science people, it's the hardening of the arteries, and everything loses elasticity as you age. You ever notice that? You get wrinkles in your skin and gravity kind of takes hold all over the place and stuff like that. And you lose that elasticity. Well, the arteries lose their elasticity and they become harder. So blood pressure goes up, you have trouble getting blood through those arteries to where they need to go. And when you look, you see that happening at a lot younger ages. And so even before the real big signs of problems with smoking, already the arteries are suffering from hardening of the arteries, loss of that nice supple elasticity that you'd normally see. There's a synergism between smoking and hypercholesterolemia, fancy name for the imbalance of the proper cholesterols in your blood. You've probably heard of them before. You say the bad cholesterol and the good cholesterol. It's really proteins that carry the cholesterol along with that cholesterol. But they're called HDLs and LDLs. You see in smokers over time, as they smoke more, you see decreased levels of HDLs and increased levels of LDLs. And that's bad because the LDLs are the bad guys, and the HDLs are the good guys, and you've got the opposite of what you should have. And so you see that over time as someone continues to smoke. Increases in something called von Willebrand factor. We'll be talking about this for you physiology people later on the semester. And you get damage to the endothelial lining, and it's going to release a bunch of chemicals in response to that damage. So one way to test and see if you've had damage to the lining of the arteries is to test for von Willebrand factor, because damaged endothelial cells release it. So you see increases in von Willebrand factor within about 10 to 30 minutes after smoking 2 cigarettes, as soon as I learned how to talk. And it increases also in inflammation, because anytime you damage the endothelial lining, the white blood cells are going to try to come to the rescue. And when they try to come to the rescue, you get inflammation. And that inflammation starts becoming chronic inside the body and can last up to 30 years even after quitting smoking, depending on how long that person has smoked. Okay? Plaques from the smokers are more frequently complicated by thrombosis. Thrombosis is a scientific term for blood clots forming right on top of those plaques. And that's a problem, because it narrows the blood vessel a lot, and they can break loose and travel to smaller blood vessels and completely clog those up. So this is a definite problem. And then if you've ever had your blood taken, like at the doctors, and they test it for all kinds of things, they can test it for something called C-reactive protein. And C-reactive protein is a general kind of a marker for generalized inflammation in the body. And we know the more inflammation you have in your body, the greater the chances of getting, arterial sclerosis, atherosclerosis, heart disease, all kinds of problems. You don't want inflammation in the body. You want to keep that inflammation very low. We look at centenarians, and they have people that live to be 100. They have low levels of inflammation in their body. And that's one reason why they live to be so long, less problems. But in smokers, you see increased amounts of C-reactive protein. And then to kind of top it off, the balance between clotting and dissolution of clotting of blood is totally disrupted in people who smoke over time. And when it's disrupted, that means you form all kinds of different blood clots, especially on top of these plaques, that you normally wouldn't. And most researchers, when I was reading through all the literature, very interesting stuff, they say that it's the main underlying factor associating smoking with sudden cardiac death. In other words, having just a heart attack, bang, and you're gone. So you add up all this stuff, and then you say, okay, what we're really looking at is something like this, where you look at the arteries that go to the brain and plaque formation. And if those plaques rupture, a piece of it can travel like an embolism into the brain, block the blood vessels, stroke. Or you get, narrowing of the blood vessels that go to the wall of the heart that need, the muscle needs that oxygen, that blood, and it can't get enough oxygen, so you have a heart attack. And the number 3 leading causes of death. Definitely contributing towards that, because you're damaging those endothelial linings of the blood vessels. So far, so good, right? All right. Now, that's just the blood vessels in the heart. What about the lungs? What about the lungs? Well, let's kind of back up for a second first, because some of you are not science people, so we'll kind of look at it. You say, well, what are the lungs really, Mr. Beeman? Well, think of a tree. A tree has a trunk, lots of branches, right? Big tree. And then all the leaves at the end of the branches, right? Now turn the tree upside down. That's your lungs. Because the trachea is the trunk of the tree. That's this thing right here, And instead of the branches being all nice and solid, they're hollow, with that same type of lining, not exactly the same, but almost exactly the same as the endothelium of a blood vessel, lining every single one of these branches. Thousands and thousands of branches. We call it the conducting zone of the lungs. And its job is to conduct air to the leaves at the ends of the branches, and those leaves at the ends of the branches are called alveoli. and they're thin-walled little sacs. From the outside look like grapes, but when you cut them open, you realize they're little thin walls. And each alveolus is surrounded by a whole net of tiny blood vessels called capillaries, and this is where you exchange the gases with the blood. So you get oxygen in the blood, which absolutely need oxygen to survive, right? Carbon dioxide out, right through those alveoli. Over 300 million alveoli in one person's lungs. Wow. The respiratory zone of the lungs, where you exchange the gases. So if there's going to be damage caused by tobacco, it's going to have to be damage to either the conducting zone, the passageways that lead to those alveoli, or the alveoli themselves, where you exchange gases with the blood. So let's look at what the research shows. Oxidative stress is the main proposed mechanism by which cigarette smoke affects the lungs and all the other bodily systems. You say, what's oxidative stress? Well, it has to do with something called oxygen-free radicals. Oxygen-free radicals are these molecules that when they get in your body, they react with normal molecules in your body and disrupt their function. So they're not functioning properly. They can even destroy those molecules with the way they react with them. So the more oxygen-free radicals you have in your body, the greater the amount of damage that will occur over time. So we look at the oxygen-free radicals, and they can do things like mutate the DNA, cause arterial sclerosis, which we just talked about, and lead to chronic lung injuries, which is what we want to talk about right now. So the oxidant load proposed by cigarette smoke, substantial, huge. The tar scientifically is nicotine-free dry particulate matter. It's all the other stuff in the tobacco that's not nicotine. And that tar that's in there, it can contain as much as 10 to the 18th oxygen-free radicals per gram of tar, saturating the lungs with oxygen-free radicals, able to react and destroy all kinds of different things over time. And then you look at the gas component and you say, wow, there's 10 to the 15th other organic free radicals per puff of a cigarette. Whew, a massive amount of these oxygen-free radicals going in every time you smoke a cigarette or a cigar or something like that. All right, now, cultured human lung cells. You take them out, you put them into a petri dish in the lab, right? And then you expose them to cigarette smoke, 70% higher levels of 8-hydroxyl-DG. 8-hydroxyl-DG is a molecule that we look at, we call it an assay. We look at it to see if there's been damage to the DNA. It tells us if the DNA has been damaged. So the higher the level of those, the greater the damage potentially to the DNA. Look at the amount, 70% higher than unexposed cells. And you say, well, wait a second, Mr. Beeman, wait. That's in the lab. That's culture. What about in somebody who actually smokes? You know, did they take the tissue out of the lungs and check that? And when you take the DNA from lung tissue of smokers, 42% higher levels of that same molecule. Evidence that there's damage occurring to the DNA. Probably one of the main causes of lung cancer, right? Changing the DNA, causing cancer in those cells. And if you look, the non-smokers, it's 42% higher, but this increases according to the number of cigarettes that are smoked. So it's dose dependent. So the more cigarettes you smoke, the greater the amount of potential damage occurring to the DNA. This molecule is called 8-hydroxyguanine, and that's what 8-hydroxyl-DG is. You also find it in the white blood cell DNA of people who smoke. You find it in urine. So you can test those. When you test the white blood cells, the urine of smokers, levels at least 90% higher than non-smokers. So you're just inundating the body with these oxygen-free radicals capable of doing quite a bit of damage. Exposing human plasma or saliva to cigarette smoke increases the protein carbonyl levels. And you say, what's that? It's another assay. It's a way to look at if there's been oxidative damage to the proteins in the body. And proteins make up structure in the body. They make up enzymes that allow chemical reactions to occur in the body. So you're damaging those. Concentrations up to 300% higher than somebody who doesn't smoke. So again, saturating the body with all of these molecules that interact and damage. Isoprostanes, those are another assay. They look at damage to lipids. Trillions of cells make up your body, and every plasma membrane is made up of lipids. Every membrane around that cell. So potential damage to all those lipids. Circulating and urinary levels of these isoprostanes, a lot higher in smokers, markedly higher than people who don't smoke. And babies of mothers that smoke have levels in the umbilical arteries and veins more than 110 times higher. These are the arteries and veins that are in the umbilical cord, carrying the oxygen and nutrients back and forth to that developing baby. All right? And then you look here, antioxidants. Just to kind of finish off what I'm saying here, and it's not a good story, and that is that the antioxidants, which are the natural molecules you find in your body that interfere, they get in the way and react with those oxidant molecules so they won't damage your body, they're really low. A lot lower in people who smoke, including ones you take in your diet, like vitamin C or beta-carotene or something like that. So the levels of antioxidants that are supposed to be fighting against this oxidative damage are lower in people who smoke. So this is not good. When you add up all this stuff and then you look at what kinds of diseases you can get, it turns into this category, this huge category called chronic obstructive pulmonary disease. And it includes things like asthma, smoking-induced asthma. A person that would have never gotten asthma in their lifetime, but they get it from smoking. And that happens over time. It's hard because when you look, you say, well, every time you pick up one of those cigarettes, you don't say, this one's going to kill me, because it doesn't. It's an accumulation over time, right? So that's what you have to kind of think about of all this damage that's occurring. Bronchitis. We know all about bronchitis. We had an epidemic of, the flu, right? And all kinds of people getting bronchitis. Coughing all the time, irritated, conducting passageways, right? The conducting zone of the lungs. That happens chronically in a lot of people that smoke over time. Chronic inflammation and damage to the passageways that lead to those alveoli, the leaves of the tree. And when you look here, emphysema, this one's the worst one because it affects the alveoli, the actual respiratory zone where you're exchanging gases with the blood. And the alveoli get really big compared to the blood vessels. You have a surface to volume ratio that's totally disrupted, and you can't get enough oxygen in the blood. Do you know that emphysema, I was reading a number of different articles, very interesting. They were saying that if everybody stopped smoking in the whole world, that the incidence of emphysema would go down, in some reports, down to like instead of where it's at right now, to less than 2%. Wow. So main causes of emphysema, tobacco. And this emphysema is so bad that when people get, when it gets really advanced, you just walking out of this lecture hall would be like running a marathon. I'm not joking, because you can't exchange the gases with the blood anymore. So, you look and say, well, what does it look like, Mr. Beeman? This is what it looks like. So you say, all right, here's a normal lung. Here's a slice of somebody who was a smoker during their lifetime, and it looks like the lung has been torn apart. Both conducting zone and respiratory zone. This is what it looks like if someone keeps smoking their whole life. What happens to your lungs? That's just a slice of it. Look at it from the outside. Big difference. Don't you agree? This is what you want, and this is what you end up with. Now, it's a combination of a lot of different things, but that chronic obstructive pulmonary disease is definitely a problem. Okay? Now, that leads us to the second leading cause of death, which is cancer. And so you say, all right, there's not a whole lot to talk about here because it's just a slam dunk. Everybody knows it causes cancer. And not just cancer of the lungs, but cancer. As a matter of fact, the 2004 Surgeon General's report, that was a great report. Over 1,300 really, really good studies done over all this time that people have been smoking cigarettes. And they kind of compiled them all together into an amazing report. And when you read some of those reports on cancer, it's just a slam dunk. The chances of cancer are very high. Look, here's just one example. 159,600 individual cases of people who died of smoking-related cancers, and 78% of those were lung cancer, but a number of other cancers also. So it's not just the lungs, it's other parts of the body also that can be affected with cancer. Uncontrolled cell division caused by, a lot of times we think, these oxygen-free radicals mutating DNA and changing these cells. Okay? Mothers who smoke during pregnancy. Oh, they don't do that, Mr. Beeman. We all know now you don't smoke while you're pregnant. The number one drug that a mother takes while she's pregnant, not alcohol, not these other illicit substances, cigarettes. Cigarettes, from 15 all the way to 44 years old. And we know the problems that can occur because the damage that occurs to those umbilical arteries and veins. These are a lot of different, I don't have time today to talk about them all, but you can see a number of different problems. One of them I'll kind of point out, and that is it's very, very common if women smoke while they're pregnant to have a baby that's born with low birth weight. And low birth weight babies have problems throughout their whole life that are related to the low weight at birth. So it could potentially affect that child for the rest of their life. So, kind of interesting to look at different things. Let's just look at kind of a grab bag of other effects. Respiratory symptoms for sure. Coughing eventually develops if you smoke for long enough. Sputum production, breathlessness, increased respiratory infections, immune system problems because your immune system's constantly trying to fight off all these foreign chemicals and substances that are in your body. You're introducing them every time you take in that tobacco. Increases in bone loss in both men and women. And you see, normally osteoporosis women as they age, right? You see it in men too if they smoke. Things like hip fractures, other problems, and it affects the mouth because dental disease is very common. You get bone loss and tooth loss is huge as someone smokes over the years. As they get into their age like me, I'm 50, soon to be 51, and they get into be my age, and all of a sudden they're losing their teeth, big time. And not just that, periodontitis, problems with the gums, bleeding gums and constant problems with that, dental caries, that's cavities with root problems, all related to smoking. Erectile dysfunction. Yeah, I had one of my 115 students, I gave him a shorter version of something, talking and said, whoa, I'm quitting tomorrow. But anyways, and so you say, well, wait a second, well, it's because, again, you're going to affect the blood supply to everywhere in the body, including the reproductive organs for men and women. Cataracts, so effects on the eyes, affects macular degeneration, diabetic retinopathy. The eyes demand a great blood supply, don't they? So problems, yeah. And so problems with the digestive tract. Ulcers, more common in people who smoke. Stomach ulcers, less frequent stomach contractions, acid reflux, increased stomach acid secretion, reduced bicarbonate production by the pancreas, which helps to neutralize the acid, and you don't have that available. And then accelerating alcohol-induced liver disease. If you smoke and drink, then the chances of liver disease goes way up because they are synergistic, it accelerates it. So you kind of add all that up and you say, wait a second, he hasn't even talked about the skin yet. So you say, do you know that the skin of someone who smokes consistently over the years, it's average 10 to 20 years older than someone who doesn't smoke? Two twins here. You can tell which one smoked, can't you? Yeah. Not just that, right around the mouth. Look at the wrinkles around the mouth. Look at the crow's feet around the eyes. Look at the aging spots on the skin, age spots. Do you see that? Look at the teeth, stained teeth, halitosis, bad breath, like you were talking about. Yeah. And so you say, well, shoot, if all this stuff is going wrong when people smoke, how come they smoke still? What's up with that, And say, what is the problem? How come they continue to smoke? And here's the reason why. Right there, the brain. And that's my favorite part. Okay, so when we talk about the brain, I have to kind of explain something really quick first. In the brain, you have literally billions of neurons and glial cells. And the way they talk to each other is kind of interesting. Like, I'll give myself an example. Look at that picture on the right-hand side at the top. I'm talking to you. I'm the transmitter of the information. Your ears are the receptor. Does that make sense? You're receiving that information. Now, a neuron does the same thing. A neuron gets really close to another one, or a glial cell close to a neuron, and then they form what's called a synapse, a little space between them. They release a neurotransmitter, like me, the transmitter, and then they bind to a receptor, like your ears, on another neuron, and then get the appropriate response. Well, when it comes to tobacco, the nicotine is the problem, because the nicotine mimics a natural neurotransmitter that you have in your brain and body. It's called acetylcholine. It's a natural neurotransmitter, and it mimics it. So it gets in your brain and goes, hey, I'm acetylcholine. You with me? And it binds to the acetylcholine receptors. And some of those acetylcholine receptors are on neurons that release dopamine, another neurotransmitter, in areas of the brain that I'm showing you on the upper left-hand side there that are areas that are affected by addiction. or dependence as we like to call it now with the new definition. Okay? And dependence is something that we have to worry about with nicotine because it's doing the following thing. Let me just kind of lay out a scenario. The smoke a cigarette, you get a small pulse of nicotine. The nicotine gets in there, says, I'm acetylcholine, binds to the acetylcholine receptors, and stays there. And this induces an extra release of dopamine. And the dopamine gives you a pleasurable effect in that part of the brain that I was just showing you. And you go, that felt pretty good, right? So you continue to smoke. The nicotine builds up to a low, steady state because the half-life of nicotine in your blood is like 2.5 hours. So it stays around. If you're smoking every few hours, it's in the blood all the time. So what happens is it just slams on those receptors. It sits on those receptors. And you're like, whoa, you can't, you get an imbalance in the recycling of the receptors. They get all out of balance, and you start putting even more receptors in the membrane because the ones that it's binding to become inactivated. They shut down because they just have nicotine bound to them all the time. So you get this imbalance all over the brain and body wherever the nicotine binds. Now, pathological levels of receptors build up inside the cell that's responding. And then during periods of abstinence, when you go to sleep at night or you're trying to give up smoking and it's the second day, you with me? You know, and you're like, you see what happens is that the nicotine levels drop back down and those receptors come back, they get activated again. They're like, oh, it's no longer bound to me. So with those receptors active again, what happens is you end up with pathological levels of receptors. They're all active now. It's hyperexcitable, and the symptoms of that are withdrawal symptoms, irritability, and you get this real drive for another cigarette. And you're like, man, I gotta have that. I don't feel well. And so the smoker self-medicates and says, I'm going to pull out another cigarette. I've talked to a whole bunch of smokers since I learned that I was going to give this talk, and I asked them the same question, every single one of them. I said, listen, which cigarette is the best one of the day? 99% of them told me it was the first one in the morning. Why? Because all night long you've been releasing the nicotine from those receptors, and now they're active, and you wake up and man, I need that cigarette now. Does that make sense? And if you're trying to give it up, it's really hard because you are dependent on it. And that's the step that you have to realize, is that it becomes a vicious cycle. And nicotine has side effects also, a bunch of other side effects. Nicotine is a major contributor towards the heart disease, towards gastrointestinal problems, towards problems in the brain, even in the joints. Nicotine can affect the whole body. Why? Because it binds to any acetylcholine receptor anywhere in the body. Does that make sense? So, it's mimicking acetylcholine. So you try to give up, and it's really, really hard. Why? Because you've got to face it. You are addicted. You are dependent on this thing. And the only way you're going to ever stop smoking is, for a lot of people, it's very rare to see somebody just say, you know what, I'm giving it up. Like my dad did, he just cold turkey, bang, stopped. That's rare. But then when he was 71, died of lung cancer that spread to his brain because he already had the seeds of cancer in his lungs in his 40s. And it just took time. Gave up a little too late, But that's the way it is. Love you, Dad. So anyways, so the whole point is, is that you got to look at this and say, wait a second, all right. So if I'm going to give up smoking, I've got to get physical help on the addiction, the dependence. I'm going to have to wean myself off the nicotine. And I'm going to have to get psychological help. Psychological help. That means you've got to say, listen, I need to go get, you should plan on failing at giving up smoking at least 2 or 3 or 4 times. Maybe not, 17,000 times. But you get the idea. Before you're finally successful. It's going to happen because you are dependent upon it. So even though all that bad stuff, people still smoke because they don't like the feeling of what it feels like if they're not smoking. And you have to get through the withdrawals. Just like if you were addicted to heroin or cocaine or something like that. All right? That's tobacco. Marijuana. Okay? All right. So finally, you get to talk about marijuana. All right. How does marijuana affect the body? Okay, well, to learn about how it affects the body, we have to do a little history real quick, okay? In 1964, they discovered the actual active ingredient that causes someone to get high when they smoke marijuana. Delta-9 tetrahydrocannabinol, or THC for short. Now, that's 1964. Now you go, whoop, fast forward, 1990, 1991, they discover CB receptors. In other words, from 1964 to 1990, 1991, we really didn't know how the THC was really working in the brain. Does that make sense? We had some ideas, some studies. Most of the studies were very poorly done and really not a whole lot. So our knowledge base was very low. Not only that, the marijuana was listed as a Schedule I drug, and it was really hard to get to do studies on. And, it's difficult. It's now a Schedule III. It's a little easier to do studies on it. So these receptors, called CB receptors, because they're cannabinoid receptors. Marijuana has THC in it, and THC is a cannabinoid. It's a class of molecule called a cannabinoid. And the cannabinoids, if you look, you say, well, God, the researchers found the receptors, and that's what THC binds to, among a few other types of receptors, which I'll talk about. And so they said, well, wait a second, if we've got cannabinoid receptors in there, the very next year, 1992, 1993, they discover, an andamide, an endogenous cannabinoid. You have your own endogenous THC that you produce in your own brain and body. It's not THC, it's your own neurotransmitters. There's 3 different ones we've found so far. And they bind to those receptors. So is THC doing the same thing as nicotine? Remember, nicotine bound said, I'm acetylcholine, and binds to the acetylcholine receptors, right? This THC says, I'm an andamide. Doesn't it look like it? Binds to the same receptors and causes effects that are going to disrupt the normal activity. Let me give you some examples. This is the skeleton key now, binding to CB1 receptors found in the brain and in the body, mostly the brain. CB2 is found in the body, mostly the immune system, and the brain too, some. So you start looking at them, you say, all right, what's going on? Well, let's just take memory, because everybody knows that marijuana definitely affects memory. So let's just look at that for a second, all right? So you say, all right, there's episodic memory, semantic memories, procedural memories, working memory. That's the big one that marijuana affects the most. That's short-term memory, that's attention, paying attention, things like that. Does that make sense? All right, so here you have one neuron, or a glial cell in this case. We just discovered it's actually glial cells, releasing information, glutamate, to another neuron and getting it to form a memory. You with me? Then in response to that, this cell will backwards release an endocannabinoid, like an andamide, like THC, but you make it yourself, and it binds to a receptor on the one releasing the glutamate and says, I'm going to modulate what you're doing. I'm going to adjust it. I'm going to fine-tune it so that you get this memory set just perfect. Now imagine you smoke a joint. I know. And inside that brain, you get a massive amount of THC. You with me? Does it get in this synapse right here and start binding to that receptor instead and causing problems? And it affects memory. We've just had, I don't have time to talk about it today, but we just came up with one of the proposed mechanisms, an article right at the end of 2012, really interesting stuff for someone like me, as to how exactly this process occurs to mess up memory in the hippocampus. It's an area of the brain that they measure to see if it affects memory. The hippocampus is an area of the brain that is really involved in memory formation. One of the areas. It's a major one. In people that are marijuana dependent, see, you have to do the right studies. If you study somebody who smokes marijuana like once a week, like cigarettes, to smoke a cigarette once a week, the effect is not going to be as great. But somebody who's smoking it every day, is there going to be an effect? Probably. So they study these people who've been smoking marijuana every day. This particular group was studying smoking marijuana, for about 3 to 5 joints a day every day for a number of years. Wow. Okay. Yeah. But you think about it, that's kind of like smoking cigarettes, you know what I'm saying? So it's kind of like that. And anyways, and they found that the size of their hippocampus, memory formation, 12% smaller on the average than somebody who doesn't smoke. And look at this. The amygdala, that's an area of the brain that deals with how shall I say it, anxiety, fear, emotions. Smaller also. Okay? Now, since there's CB receptors all over the place in the brain and body, And there's all these parts of the brain, which I don't have time to talk about today. And here's all the things they do. You can read it while I'm talking here. And then here's all the different effects that THC can have because it's getting in there and it's mimicking normal endocannabinoids. You with me? So can you have all kinds of different effects? Definitely. So once they discovered the receptors and the anandamide and other endogenous cannabinoids, the researchers thought, whoa, like 1995, 1996, they're saying, wait a second, we could possibly use marijuana as a medicine. The THC, what if we could use it as a medicine? So they said, oh, is there a therapeutic effect? Could we treat people that are cancer patients for pain, or maybe cancer patients for the nausea that comes with it, or maybe AIDS patients to get them to eat because of the marijuana munchies and all that kind of stuff, right? You know, it stimulates the appetite, right? So they said, all right, could we do some, and so let's look at what we've come up with so far. I've taken all the, I read a ton of different research articles, very interesting stuff, and I just summarized it here. So let's look at the anti-nausea effects of marijuana first, okay? Well, it's definitely effective. It cuts nausea. But there's a very narrow window in all the research I read, and I read a lot, between the anti-nausea dose and unwanted psychic effects because remember, you're going to bind to any CB receptor that's there in the brain. So they've come up with better drugs, like serotonin receptor antagonists. They're better. They're more powerful, and they have better, they treat it better. So are they using THC to treat people for nausea? Not at this point in time. The psychotic effects are too much. They can't seem to control it. All right? Let's try multiple sclerosis. THC can relieve muscle pain, spasticity in patients, can control tremors in animal models. So it definitely works, but if you smoke marijuana, you cause impaired posture and balance in a lot of different people, a lot of patients. So by smoking it doesn't, so they use the isolated, purified THC instead to try to do the experiments instead of smoking it. Matter of fact, when I look through the literature at how many studies they did where they used smoked marijuana instead of just isolated THC, hardly any, and very poorly designed. It's all isolated, purified THC that they're using because they can control the dose levels. It's really difficult to control the dose levels in the smoked form of marijuana. And then you get the same thing. If you try to treat people with MS with THC, you get all these psychiatric effects and effects in other systems too, like the gastrointestinal system, digestive system and stuff like that. So a lot of side effects, so not too much use in multiple sclerosis. Glaucoma, get rid of that intraocular pressure in the eyes. In lab animals and humans, definitely works, but patients have to stay at very high levels of the THC, and they have to stay under it continuously to get the optimum effect of that, that relieving the pressure inside the eyes. So we've come up with other drugs like prostaglandins and other drugs that are better, and they can be administered at lower doses with lasting positive effects. So THC is not used to treat glaucoma. How about appetite? Here's where it's still used. Because it stimulates appetite in the hypothalamus, the area of the brain for that, they use it to treat cancer patients and AIDS patients. They still use it. So it is used to treat lack of appetite. All right? So that's one area where it's still being used. All right? Analgesia, pain relief. THC has some analgesic capabilities. It definitely does get rid of, ease the pain because it binds to opioid receptors also, not just CB receptors. And opioid receptors are the receptors for something like morphine, our strongest pain relief medication that we give like in hospitals, right? And so it has some pain relief, but the therapeutic dose, the window between doses that work to give you pain relief and those that produce unacceptable psychic effects on that patient is very narrow. So they don't use it. They use something that's more predictable. And, I just was so amazed at how many studies that were done with THC and how many that weren't done with smoked marijuana, and yet that's all they're talking about is that, we're going to use, we're going to legalize marijuana so we can smoke it and use it for, but there's hardly any studies. So it's kind of crazy. So I start looking at things like this where, to get a repeatable dose, it's really hard to do with smoked forms of marijuana because the plants that you take it from and the other cannabinoids that might have pharmacological effects with the THC, and there's a lot of different factors that play in that make it hard to get controlled doses of smoked forms of marijuana, and it absorbs in the body super quickly when you smoke it. It takes about 30 minutes or so if you take it as THC. So you, as a researcher, you use the THC instead because you can control the studies. And the studies that have been done with smoked forms have been given to relatively young, medically screened, healthy male volunteers that are well experienced in the effects of marijuana. Does that make sense? Is this the ideal studies? And the clinical pharmacology of single or repeated smoke doses given to like older people or people with serious diseases hardly studied at all in a smoked form. I was shocked by that. I thought they had done a bunch of them, but as I was doing the research, I'm like, wow, they really haven't done hardly any at all. Most of the studies suffer from small numbers of participants. You need a lot of people, right, in both control and experimental groups to get ideal studies. And you're not seeing that. So with those limitations, with the understanding that most of the studies have been done with THC and most of the studies have been done on people that have long-term problems, in other words, they're essentially marijuana dependent. They're living on it all the time. Here's what we see right now. More studies need to be done, absolutely. But here's what we see at this point in time, since that's the talk I'm giving. People that smoke marijuana on a daily basis, problems with their corpus callosum. Huge studies, 2 big studies I read, very, very well done, and they look at the corpus callosum, and definitely damage to the corpus callosum is the connection between the right and the left part of the brain. It allows it to talk to each other, and there's damage there. Those fibers are damaged. That's a problem, How about volume reduction? We showed you that. The hippocampus, the amygdala, remember memory, emotions, reduced in size. And marijuana severely impacts short-term memory, especially attention. I don't know about you, but that sounds rough on a student, right? Trying to pay attention in class. Some long-term heavy users suffer from psychotic experiences. And that's not good either. The loss of memory in some cases equivalent to 15 additional years of aging. Slow brain potentials. This is really interesting. In the peak intoxication periods after you smoke a joint, let's say, about 20 to 30, 40 minutes later, you see the lateral prefrontal cortex damage to it that goes away after you kind of recover from it, which is good. Your body's amazing, its ability to recover. But the damage is the same as the damage you see in people with lateral prefrontal cortex lesions. These are people that have problems with, how shall I say it, executive function. That means they don't know how to work properly with other people in society, and they say things at inappropriate times, and do you understand? The most famous person for you biologists out there was Phineas Gage, when he got the big pole through his head, And so if you've ever, heard about that. And so you see that in people who smoke on a regular basis, marijuana. Problems with functional MRIs and PET scans where you have activity in areas that you normally wouldn't and less activity in other areas. What does that mean? We don't know yet. More studies need to be done. Deficits in some areas, alterations in some areas. We're not sure. More studies need to be done. Some marijuana users suffer from cannabis psychosis, symptoms of paranoid schizophrenia. And there's been a number of studies, 2 really good ones that I looked at, that show that if you have a genetic risk for schizophrenia, and you smoke marijuana as a teenager, your chances of getting schizophrenia is moved up in time. Like you might be only 25, 26, and you get schizophrenia. So it's, the combination of genetically predisposition and the actual, the actual smoking of marijuana as a teenager, they work synergistically. It seems like more studies need to be done. There's an association between marijuana use and depression, bipolar disorder, panic attacks. I'm talking about regular users here, okay? Also in some users, addiction, definitely, and withdrawal symptoms. In Washington and in Colorado, right, they legalized marijuana, right? Maybe in California here pretty soon. And so if you look at it, they are planning on addiction. They're planning on addiction. One of the big players right now, they're interviewing her constantly. She's a professor, Angela Hawken, at Pepperdine University, public policy professor, and she says over and over again, we're going to have to plan for addiction because it does happen. Dependency on marijuana. Okay? Impaired perception, judgment, motor skills, problems. Look at this. You become marijuana dependent, and look at the incidence of every single type of mood and anxiety disorder compared to the general population. All of them higher. You don't hear about this, do you? I didn't hear about it. I went in studying this stuff, and I'm like, wow, this is pretty interesting. Okay? You look here, well, what other effects? Daily use of 1 to 3 marijuana joints a day appears to produce the same amount of lung damage as about 5 times as many cigarettes. Why? Because you smoke it differently. You hold it in, right? Yeah. The same lung cancer risks associated with tobacco also apply to marijuana users, even though they smoke less. One average marijuana cigarette contains more benzopyrene, the number one ingredient that causes 70% of all the lung cancers, and it's found at 30 nanograms in the average marijuana joint compared to only 21 nanograms in a cigarette. Okay? Marijuana smoke produces airway injury, acute and chronic bronchitis, lung inflammation, decreased defenses against lung infection, and the smoke contains as much as 4 times tar as you see in tobacco smoke. So it's definitely there. We're just not talking about it. Marijuana has adverse effects on the immune system in some people because you're constantly trying to fight off the chemicals that are there. Effects on hormone production in some people. It makes them actually, infertile in some cases, if they're smoking it consistently over time, dependent on it. Look at this. Here's a study that was done. They took 6,728 U.S. adults. They did a survey, and they asked them, hey, current asthma, chronic bronchitis, coughing, phlegm production, shortness of breath, and wheezing. How many times do you have this? And then they said, all right, now we're going to bring you in. Every single one of them they brought in and gave them a physical exam. They checked chest sounds, pneumonia, and then the FEV. We'll teach this in physiology, by the way, for you physiology people. But this is a measure of your ability to the obstruction of the lung passageways. Look at it. Tobacco and marijuana, both higher than someone who's a non-smoker. And get this, in some of the categories, look at this. Wheezing, marijuana is higher than tobacco. Look at chest sounds, marijuana, higher than tobacco. Phlegm and coughing. Do you see that? So it falls into that same kind of category, it seems like, that we saw with cigarettes. There was a time, you guys, when I was reading through the research, really interesting to read the old stuff. Because doctors thought that cigarettes might be good for you. I'm not joking. And the public, the advertising companies picked up on that, and they said, hey, old gold, great for your throat. Right? Soothes the throat. Well, since we've done enough research, we found, no. That's not the case. I'm afraid, just from all the research that I've done, that we're heading down that same pathway right now with marijuana. That if you look at the studies from 1998 to 2009, 10 or so, there's more negative results we keep getting rather than positive or neutral than we got before we discovered those receptors. So it looks like we're traveling down that same pathway to where it's gonna be, hey, this stuff there's no good in it. Do you know what I'm saying? I might be wrong. I might be 100% wrong because we're in the very infancy of studies right now. Here's a really interesting study, and then I'll get to the last part and we'll be done, and that will be hookah. But check this out. A very recent study just came out. They took the town of Dunedin, New Zealand, took everybody that was born in 1 year between 1972 and 1973, and they put them into this study. Everybody. So rich, poor, whatever, everybody in between. So all different social classes. And they put them and they studied them for 30 to age 38. Okay? And they just published this study. And they said, all right, and they interviewed them at different ages to see how much marijuana they smoked and stuff like that, right? And then they gave them a IQ test at 13 years old and another IQ test at 38. Those who started smoking when they were teenagers, dramatic effects. An average of 8-point drops in IQ. That's like taking somebody of average intelligence and dropping them down to a lower 1/3. And when they stopped, if they started smoking as a teenager and then gave it up as an adult later on, those IQ problems were still there even after they stopped. It was permanent. That's a problem. And therefore, they're worried. They're worried about, hey, who smokes marijuana? Teenagers and young 20-year-olds, right? Who smokes marijuana in high school? The number one abused drug in the world, but especially in the United States, 12th graders, right? Cigarettes going down. People aren't smoking as many. Why? Big advertising campaigns, right? Hey, it's bad for you, not good. Even pictures on the cartons now in other countries, right? And maybe that'll happen here. Here, marijuana is on the rise. Hey, Barack Obama smoked it, so I'm okay, right? You see what I'm saying? It's kind of, hey, people just think, hey, it's okay, there must be nothing wrong with it. But that's not what the research is showing. So you look at those young, developing minds. And what do you see? Under construction, right? The areas of the brain especially that develop are the ones that are for that executive function, the ability to work and survive in society, and that's the people that are smoking it. That's where it starts. So it's pretty interesting to look at it. All right, last one, hookah, and then I'm done. With hookah, it's all about the pipe. I'm not joking, because you're smoking tobacco. So let's just show you how the pipe works real quick, and then I'll be done in a few minutes. All right, the pipe is set up right here where you have charcoal on top of something like tin foil with holes in it, little tiny holes, or a wire mesh, and then underneath that you put your tobacco. But the tobacco is moist. Moist. When you burn, you start a campfire with dry wood, or you start a campfire with slightly moist wood, which one produces more smoke? The moist, the wet wood, right? So this wet tobacco is producing way more smoke inside of a hookah. Do you understand what I'm saying? All right, so you get this lit up, nice and hot, indirect heat. It heats up the tobacco. You start producing smoke. It comes down through this tube, and then it's barely dipped. It's just sitting below the water in a bowl at the bottom. There's water in there. And then so the smoke goes through the water, and then it collects in this little chamber, and then you breathe it through a little tube with your mouthpiece, and you smoke it, right? So here's the biggest misconception about hookah. Because it bubbles through the water, it takes out all the bad things in the tobacco, Mr. Beeman. All right. Well, remember, it's tobacco. We talked about tobacco. All right. Let's look at what the research says. This is quite interesting. Most of the research has been done in the East, India, Pakistan. So there's some good studies. There's a couple really good studies that I'm pulling from right now. Smoke produced from the water pipe, then they measure the smoke coming out of the actual part where you smoke it. So they're measuring after it's gone through the water. It contains carcinogens, carbon monoxide, heavy metals. Water pipes are used for periods of 30 to 45 minutes. You go to a hookah bar, a hookah cafe, you sit there for a while with your friends, you smoke it. One cigarette is smoked during your cigarette break for about 5 minutes. So let's compare the two. Yeah. An average puff on a water pipe produces 500 milliliters of smoke. An average puff on a cigarette, about 50 milliliters of smoke. Hookah smoker takes 100 puffs roughly in a 30 to 45 minute period of time. A cigarette smoker takes about 10 puffs. Right? They finish up the cigarette. Water pipe, let's do the math. 100 puffs times 500 milliliters of smoke each, 50,000 milliliters of smoke, or 50 liters per session. So in that one session, imagine 50 liters of Coke, empty the Coke out, fill it up with smoke. That's what you're putting in your lungs. 50 of those. Pretty amazing. Cigarette smoker, about half a liter of smoke that you end up putting in your lungs. Okay? Smoke from a water pipe, 2.96 milligrams of nicotine per session. Cigarette smoke, about 1.74 milligrams of nicotine per cigarette. Tar, remember that dry particulate matter? All those chemicals that are bad for you? In water pipe smoke, 802 milligrams per session. Cigarettes, 22.3 milligrams per cigarette. About 36 times the amount of tar in a water pipe session. Remember, you're going for 30 to 45 minutes. With your buddies, your friends, you're hanging out, right? Carbon monoxide, the #1 cause of heart disease and problems with your blood vessels, 145 milligrams per session. Cigarettes, 17.3 per cigarette. Big difference. Heavy metals, cobalt, arsenic, chromium, lead. Oh, I don't know about you, but I don't want those in my lungs. All right, so let's finish this up. Who smokes it? Yeah, check this out, you guys. New study just came out, 2012. They interviewed. Who smokes it? They were interviewing women, freshman college women. 23% reported they experimented with hookah as a freshman. Big time. Because it's social. You hang out with each other. The tobacco's flavored, awesome, and it goes through the water, so it cools it down, makes it easier to smoke. So you got the nice flavor, you got the coolness of it. You're not coughing your head off trying to smoke it. You with me? And you hang out with your buddies. So they did a study in 2008, 235 hookah users in San Diego cafes, right? And they said, oh, wow, 35% of them smoking it every week. Every week. College students, that's who smokes this stuff. 58% of them said it was less harmful than cigarettes. Not what the research says. So my question is, okay, don't be fooled. Don't be fooled. Don't be fooled. It's tobacco, folks. It's tobacco. It's just going through a water pipe first. It's the same thing. It's tobacco, okay? So, don't pretend like it's something else when it's really not, all right? And that's it, you guys. I just have a list of some references. And then, hold on a second. Hey, if you're looking at trying to quit, your body can recover. It's amazing. I'll leave that up there so you can take a look at it.